Hello, and welcome to our chapter summer installment of the Living Well with ALS webinar series. We are thrilled to have each and every one of you join us today for this exciting webinar. My name is Rumana Barudi, and I will be your host for this session. In the next hour and a half, we will be diving into today's topic of the Living Well with ALS program, titled A Guide to Neuro-Palliative Care. This topic will focus on how neuro-palliative care in the clinical setting can complement the community-based palliative care to support people living with ALS and their care partners. Whether you are a person living with ALS or a caregiver of someone living with the disease, we tailored this webinar to provide valuable insights and practical takeaways for all the attendees. Before we begin, I would like to go over some housekeeping items to ensure that everyone has a smooth and enjoyable experience throughout the session. The webinar will consist of a presentation delivered by two amazing speakers, followed by a Q&A session. We encourage you to submit your questions through the Q&A feature on the bottom of your screen, and we'll do our best to address as many questions as possible at the end of the presentation. This webinar will be recorded, and the recording, along with any relevant resources and presentation slides, will be shared with all the registered participants after the event. We will do our best to cover all the key points within the scheduled time. If we are unable to address all the questions during the Q&A session, we will follow up with you via email. Now, without further ado, let me introduce our first presenter in the evening. Ladies and gentlemen, it is my great pleasure to introduce one of our distinguished speakers for tonight's webinar, Dr. Heather Leeper. Dr. Leeper is an assistant professor at the University of Chicago, where she has made significant contribution to the fields of neurology, neuro-oncology, and hospice and palliative medicine. She has earned board certification in all three specialties, further underscoring her expertise and dedication. She has expertise in neuro-palliative care, a person-centered care approach aiming to provide support and symptom management to improve quality of life and relieve suffering from time of diagnosis through end of life for people living with ALS and their care partners. Please join me in giving a warm virtual welcome to Dr. Leeper. We are grateful for her presence here today and excited to learn from her expertise. Dr. Leeper, the virtual floor is all yours.
Thank you so much. What an incredibly warm welcome. I'm ready to flow out of here right now. So it's really my pleasure to be here with all of you. Let me get my screen sharing going here. I have actually had ALS in my own family. My dad's oldest brother died of ALS just as I was starting medical school, and his death had a profound effect on the whole family, and especially my dad, who died last spring. So in his honor and in my honor of my uncle, it's my pleasure to be here with you tonight. So I'm going to talk to you about what we can do to provide person-centered care for people who are living with motor neuron disease, but most especially ALS. So first and foremost, I have no disclosures to declare. And I'd like to just acknowledge that these slides come from the International Neuro-Palliative Care Society, and these slides were created in collaboration with a whole bunch of individuals, and we all had funding from the NIH to do this. So the objectives I'm hoping that you guys will have at the end of the talk is to define palliative medicine as person-centered care approach for people living with serious illness, that you'll be able to identify how palliative care and how hospice care are distinct healthcare services, and to understand how neuro-palliative care issues faced by people living with serious neurologic illness and their caregivers can help. So I thought I might start with just a very basic primer of some essential medical information that I thought might be helpful about ALS, which is an acronym for amyotrophic lateral sclerosis. So who gets ALS? So it turns out the incidence is only 2 to 3 people per 100,000, meaning that approximately at any given time, around 30,000 people in the US have ALS. And the typical age of onset is somewhere between 55 and 70, although that is just an average. There are certainly people who are way younger than 55 and older than 70 who also develop ALS and then are subsequently diagnosed. In terms of who survives longest, that is very difficult to say. I can tell you that the median survival is somewhere in the 3 to 5 year range. And there is a small percentage of individuals, somewhere around 10%, who live longer than 10 years. And that tends to be individuals who have a very mild version of ALS that progresses very slowly. As depicted here in this graph, around 60% of individuals diagnosed with ALS survive about 3 years. So at presentation, what does that mean? So that means when people finally seek care for symptoms that they've been having, and they're referred then to a neurologist. And at that time, the neurologist will look for key symptoms. And these key symptoms would be muscle weakness, shrinkage of the muscles, twitching of the muscles that you can see with the naked eye, slurring of the speech, difficulty swallowing, difficulty breathing. And these symptoms, in conjunction with key findings on the neurologic exam, and then special testing with electricity to look at the speed at which muscles are firing and how they're firing, how many of them are firing, getting imaging of the brain and spine to make sure that there's not some other reason why the person might be having muscle weakness, some key laboratory tests. And then there's also an assessment test called the ALS Functional Rating Scale, which we'll go over here in a minute, that assesses a whole range of different functions. These together comprise the information that neurologists use to diagnose ALS. So to talk a little bit more about symptoms that people with ALS will have and report are limb weakness, so arms and legs, feeling of stiffness, that their arms and legs feel tight and stiff. They'll notice that their muscles are shrinking and going away on them, that they'll have muscle cramping. This is particularly common in the legs. Twitching, the medical word for muscle twitching is fasciculations. Dysphagia refers to difficulty swallowing, so feeling like you always have a lump in your throat, or when you go to swallow food, like you feel like it doesn't go down all the way. Dysarthria is the medical term for slurring of your speech, so sounding like you've got marbles in your mouth, or that you've had maybe too much to drink and you're just not able to get your words out, you're swallowing your tongue, all of those kinds of euphemisms. And then dyspnea and orthopnea refer to shortness of breath, or a feeling that you can't get enough air. And orthopnea refers to feeling like when you lie down that you can't get enough air and you need to sit up. ALS is also known to cause changes in the brain that result in personality changes and thinking impairment. And one of those things that will happen is people can laugh or cry inappropriately. So rather than laughing at a joke, they'll cry. And rather than crying at something that's sad, they'll laugh. And the medical term for that is pseudobulbar affect. And then cognitive impairment just refers to a broad range of changes in someone's thinking. So difficulty doing things that we usually can do with ease. So here's that functional rating scale that I was referring to 2 slides ago. So this is the checklist that neurologists use to rate each one of these items. And this is the scale that they use. So for example, for speech, a normal speech is given a 4, detectable speech disturbance is a 3, intelligible speech, if they can repeat what they said, is 2, a 1 is speech that's combined with nonverbal communication. For example, someone trying to say something, but using their hands to try and gesticulate to convey what they're trying to say. And 0 means loss of any useful speech. So each one of these items, so salivation refers to drooling, swallowing, handwriting, using utensils to cut and handle your food, so using a knife and fork, a spoon, chopsticks, or whatever culturally is appropriate for you. Being able to get your clothes on and off, when you toilet, being able to manage your own hygiene, being able to brush your teeth and things of that nature, being able to turn in bed, your ability to walk, ability to climb up and down stairs, and breathing. So to just very briefly cover, when we talk about ALS and its progression, what that refers to and the timeline of that. So the symptoms of ALS and the rate in which the disease seems to be progressing, judged by symptoms that I just shared with you, they will vary from person to person. However, there are symptoms commonly associated with different stages of the disease. And when these are present is when the neurologist and the team can declare where someone is in the stages, and being early, middle, and late. So this is typically how ALS progresses. So early stages tend to be muscle weakness and the twitching, cramping, feeling tired, having difficulty balancing when you walk, and that has to do with weakness, and then slurring of the speech. The next stage, people will have even more muscle weakness. Some muscles won't work at all anymore. Difficulty with swallowing will start being present. Difficulty eating and chewing and swallowing together will be difficult. So meals will take way longer than they used to. People report breathing issues, so feeling like just minimum amount of effort will cause them to feel short of breath. And then that uncontrollable laughing and crying that I described earlier will start maybe showing up, if it's going to happen. And then in late stages of ALS, there's paralysis in most muscles. There's extremely limited mobility. Speech is pretty much lost. Inability to breathe without assistance of technology, assisted devices is lost. Inability to eat without assistance and inability to drink without assistance is present in the very late stages. And ultimately, the cause of death for most people who have ALS is related to respiratory failure. And that's because the disease progresses to the point where your muscles are so weak, not just the external muscles around the rib cage, but your diaphragm deep inside, that the lungs just aren't able to fill with air and be able to exchange oxygen and carbon dioxide. And that is usually how people with ALS die. So how do we know who's going to have what disease course? So we don't have a lot of information on this, actually. There's a real gap in the research base of this. But what I can tell you is that people that the neurologists have identified as having a shorter prognosis are people who have bulbar onset. And what that refers to are muscles isolated to the face and the neck, especially the face. And that's because swallowing ability and breathing ability is so key at that level of the body. People who have a body mass index of less than 25 and people who are older than 75 tend to have shorter prognosis. People who have a longer prognosis tend to be people who have disease onset in an arm or a leg, people who have a body mass index of over 25, younger than 75 years of age, and people who don't technically have ALS, but rather a similar disease that is affecting only the upper motor neurons. And that refers to the neurons that are going from the brain to the spinal cord only, and not those neurons that are in the spinal cord going out into the body. So this brings me to talking about prognostic uncertainties, which refers to the difficulty in sorting out in the early stages, usually before 4 years, who really has ALS versus this other condition that I just referred to, PLS, which is just the upper motor neuron variant. And that can be really difficult. So neurologists often need extra time for symptoms to develop for them to be able to tell you. So what treatments have been developed thus far to try and slow this progressive loss of the motor neurons down? So as of right now, there's 2 drugs. The first one that was approved is Relutech. That's the trade name. And it was approved in 1995. And it's rather expensive. The cost varies between $500 and $1,000 a month, depending on insurance coverage. And it seems that the benefit is rather modest, where even though you take it every day, twice a day, it seems to only prolong life by 2 to 3 months. This seems to maybe be greater in those individuals who have the onset of just in their face and they're affecting their swallowing really early in their speech. But the data on this is not great. So the patients that we think most likely benefit are people who have had symptoms for less than 5 years, have a breathing vital capacity. This is a test that the pulmonologists have to do that's over 60% of predicted for your body size, and people who don't have a tracheostomy. So the other medication is Radicava, and it was approved in 2017, and it is rather expensive. The annual cost for this drug is $146,000, and it is an infusion that you have to do daily for 2 weeks at a time, on and off. So it seems that it slows the functional deterioration in about 1/3 of people who have early stage ALS, but there's no good data that shows that there's an actual survival advantage, and there's no long-term studies. So it's considered to be an adjunct to Relutech. So those are the only 2 medications intended to treat the underlying cause or mitigate the underlying cause. So with that primer on ALS, let's move into talking about what is palliative care. So the way I like to talk about palliative care with my patients is that palliative care is about living as well as you can for as long as you can. And this is something that many of us in the field talk a lot about with those that we have the privilege of caring for, and their caregivers, their family members, their care partners, because really that's what we're trying to do. We're trying to do everything we can to support the person and their family with managing symptoms, through coping and navigating all of the complex medical decision making, and doing everything we can to maintain quality of life and support the goals and the values and the desires of the person and their family. So palliative care is actually appropriate at any stage of illness, including at initial diagnosis. I'm a big proponent of meeting palliative care needs from the time of initial diagnosis, because that can do a lot to allay worries and fears that can be addressed early on and mitigate a lot of distress that people carry, worrying about things that could have been addressed beginning. Palliative care is also dedicated to high quality communication, impeccable symptom management. Palliative care is not the same as hospice, which we will get to later. It's not about withdrawing care, but rather tailoring care to the needs of the person as their care needs evolve over time. It's not about doing nothing, but rather focusing on what's most important to the person and what they said that they wanted most. It's not just for the eminently dying, it's for the entire illness course, regardless of where the person is in their disease trajectory as categorized by the neurology team. And it's not really intended to be only provided by specialty palliative care physicians, so people like me that have board certification, but rather the neurology teams as a whole, and having them be able to meet these same needs. So I'd like to explain why this juxtaposition is important. And that is that the usual practice of medicine is here depicted here on the left in the biomedical model, where the disease is at the center of the medical attention. And all of the efforts are focused around trying to diagnose the disease, identifying what's causing it so that an intervention can be found and delivered to try and mitigate the disease. Palliative care, along with hospice care, nursing, speech therapy, occupational therapy, rehab therapy, speech and swallow, pathologists, all of these other services, they operate more so under the biopsychosocial model, where the person experiencing the illness is at the center. And we recognize that that illness experience is made up of the person's social background, like who they are to their family members and their care partners, who they are psychologically, like personality traits, how they feel, like meaning their mood and things of that nature, in addition to their biological factors, including their, the disease, of course, but also how they perceive their body, their gender identity within the social space. So it all comes full circle. And so I think that people with serious neurologic illness need and benefit from both of these models of care delivered together. And I believe that's true irrespective of exactly which disease it is. And that's because we are ultimately all people, and not a disease, but rather a person living with the disease. So just to briefly explain what this looks like in care within the US healthcare system, such as it is. Disease-focused care, for example, will focus on disease-related medical symptoms. And in person-centered care, as is practice in palliative care and other disciplines that use the biopsychosocial model, is to focus on the multidimensional symptoms. So physical symptoms, psychosocial symptoms, spiritual distress, and practical issues and concerns, improving the overall well-being of the person and reducing their suffering, affirming and valuing life while planning for the inevitability of decline and end of life, focusing on the individual and whoever they consider their partners and family, and approaching this with an interdisciplinary team approach. And this is somewhat different than the disease-focused care because they're pretty focused on just the physical aspects of the health, prolonging life, focuses pretty much only on the patient who has the disease, and there's kind of variable use of team. Obviously, multidisciplinary ALS teams are the exception rather than the rule in the US healthcare system. So to briefly cover, when you hear people talk about palliative care, and you hear primary palliative care, what that's referring to is what all physicians should have as a basic skill set as part of being clinicians caring for people. So that's basic management of pain and symptoms, basic management of depression and anxiety, and being able to have basic discussions about prognosis, goals of treatment, suffering, and and figuring out code status, referring to if someone's in the hospital, for example, and extremely ill, what they would want if they became sicker or even their heart stopped and their breathing stopped, meaning that they would have died, versus someone who is early in their disease and still is relatively healthy, and they might want to still be full code. So it's important to have these discussions and clarify what is meant and avoid euphemisms. I think we also want to be able to have physicians be able to recognize when people are having emotional and spiritual challenges so they can be referred to appropriate providers. Care partners should also be recognized for needing resources and support and being referred appropriately. And patients should have the ability to be timely referred to hospice at the end of life when that is appropriate. And physicians should also be able to respond to hastened death requests. Specialty palliative care refers to people such as myself who had additional training and fellowship, and refers to us being able to have additional expertise in serious illness communication, which I will talk in a few slides later what that is exactly, helping patients and their families navigate complex medical decision-making, complex psychosocial, spiritual, and psychological distress, complex interfamily dynamics, in addition to assistance with requesting non-beneficial care as well as hastened death, in addition to having extra expertise in managing refractory pain or other symptoms, and being able to assist with decision-making amongst complex family dynamics and between medical staff and families as well. So there's this important concept that I would like to explain, and it refers to this concept developed by Cicely Saunders, who's kind of the godmother, if you will, of hospice care. And that refers to total pain. And that's the concept that sometimes people have pain that's not just physical, but rather coming from other aspects of their person. And that suffering can come from a loss of meaning of life, a loss of freedom, a loss of dignity, a fear of being a burden, a fear of dying, difficulties with reconciliation with a higher being, depending on your spiritual beliefs. And sometimes it can be suffering because of really complex social family dynamics that went unresolved. So people who have family members that they never got to reconcile with. And it's important that we recognize that people can hurt for more than just physical reasons, and those deserve just as much recognition and management as others. So as I promised, we're going to briefly talk about what serious illness communication is. And it's basically a framework using skills and techniques to support discussions between clinicians, individuals who have serious illness, and their family members. And it's intended to guide, using a person-centered approach, physicians through, in a structured way, finding out what's important to the person, and using this to inform shared decision-making and helping identify care that is concordant with the person's goals. So this focuses on listening and discovering what really matters physically, psychologically, existentially, relationally, referring to relationships that the person has. And these discussion topics include illness understanding, preferences around receiving information preferences around prognosis, key concerns of the person and family members, such as goals, priorities, fears, worries, critical abilities, family involvement, and then last but not least, clinician recommendations about how the disease might unfold and the care options that might be available to them as time progresses. So let's switch gears and talk about neuro-palliative care specifically for people with serious illness, namely ALS. So just to let you know, the American Academy of Neurology does have a position statement about palliative care being defined as an approach aiming to improve the quality of life of the person with the life-altering illness and their families through preventing and managing physical, psychosocial, and spiritual suffering, and that palliative care is not seeking to hasten the end of life, but rather to help patients have the best possible quality of life for as long as possible, while recognizing inevitability of death and providing comfort and dignity whenever that end of life comes for the person in question. And that there's a real need for more neurologists to have primary palliative care skills. So what is it that makes neuropalliative care so unique relative to all the other patients? And I would submit to you that people who have ALS are much more likely to have motor impairment and cognitive impairment simultaneously that will cause them to lose their ability to communicate, and therefore make it a lot harder for those of us caring for you to know what you want and what is most important to you, so that we know how to meet your needs and provide care that is concordant with your wishes. So I am a big proponent of having discussions early so that we know what's going on, at least at the beginning, so that as time goes on, we can revisit when as much as we can what's important and what's changing. And that there's also behavioral changes like this inappropriate laughter and crying. There can be depression. There can be people just become different people because of the loss of the neurons in the brain that causes the family members to have a lot of distress. And all of these together on top of a high degree of prognostic uncertainty can really cause a lot of stress and strain at home with families. And navigating all of this is a lot. So palliative care aims to help with all of these things through coping, acknowledging what's happening, and strategizing how to navigate all of these situations as they arise. There's also an important evolution or drift of a person's view of what's acceptable over time. So for those of you who haven't read Atul Gawande's book, Being Mortal, I highly recommend it. And I find this quote to be really valuable in that, us as physicians, we have a failure on our part when we fail to recognize that people who have sickness that is taking their life in the end have priorities that are beyond just being safe and living longer, and that it's our job to address these concerns and open the floor to you about communicating what those concerns are. So people who have serious neurologic illness, what they've said that they want and need is their diagnosis presented in a compassionate, supportive, and transparent manner, that they want a recognition and management of their complex symptoms, that they want to have coping for their grief, guilt, anger, frustration, and loneliness. They also want support and strategies for engaging in their social roles as much as possible in activities in the new context of their illness and confronting existential and spiritual issues, that they want to have iterative advanced care planning discussions, and then when the time comes, provision of timely and supportive end-of-life care, which for some individuals may well include hospice per their wishes. Caregivers have different needs. They often say that they face rather different challenges, and that they seek anticipatory guidance for managing the behavioral and cognitive and physical changes, as well as all of the psychological, legal, and financial concerns that arise as a result of all of these changes in the person's neurologic function. That they seek support to discuss their own self-care, as well as their own grief, guilt, anger, frustration, and loneliness. And that they seek support and direction to community resources, support for learning how to use and receive care for medical devices and home health services. And then after their loved one has died, bereavement support, which is, I think, one of the biggest benefits of hospice care for caregivers. So people living with and through ALS and their caregivers need a map. They want to know where they are now, what their options are. They want to figure out where they want to go next. What does that look like? How fast they are likely to move in the direction that they want to be moving, and what signs to look for to indicate they are in fact moving in that direction. They also want to know, if I'm not moving in that direction and the worst case scenario is happening, how will I know that that is actually what is upon me? So within this roadmap, I think that there are opportunities along the way that palliative care can be broached, in addition to just introducing the concept at the time of diagnosis. So that can also be when there seems to be disease progression and or the person is declining in their functioning, when they need to be referred to the emergency department or hospitalization or even urgent care, when there's a need for IV medications, when there's progressive neurologic symptoms and not just function, when there's a lot of psychosocial issues that are arising and the need for escalating care, and also at routine screening at return visits. So every time someone returns to clinic for evaluation, I think goals of care, meaning how are things going, what is it that you understand is happening, and are you feeling like you're having a shift in your priorities? Here's what we discussed last time. Is this still what's important to you? Should all be rediscussed. And the reason for that is that there's no perfect, quote, quote, right time to start palliative care, because there is an ever-evolving continuum of issues and needs arising from the time of diagnosis, with people losing their ability to work, to drive, needing assistance with dressing, their decline, and all of the things in between. So I'm a big proponent that it's better to have frequent discussions. And in fact, a lot of these neuro-palliative care needs are under-recognized and under-treated, and that people who are living with ALS have symptom burdens that are not unlike those who are living with cancer. So the symptom burden, as you can see here in this graph, is really high. So look at the bottom line where it says the number of participants, the max being 500 in this study, you can see the overwhelming number of patients had fatigue, muscle stiffness, muscle cramping, shortness of breath, difficulty sleeping, pain, anxiety, depression, difficulty with managing their secretion, so drooling, problems with constipation. So lots of issues happening. And for that reason, I think advanced care planning is really important. These discussions can include discussions around invasive procedures, so feeding tubes, breathing assistance, code status, life-prolonging restorative care options versus focusing on quality of life, all of those things. Filling out advanced care directives, which cite who you would want to be the person to provide medical decision-making when you're no longer able to do so, all of those things. And the reason why this is so important is that quality of life perceptions can evolve over time. So people can go from saying, I'm fine with a wheelchair to saying I'm not actually. People can say I would never want a feeding tube to say, actually, maybe I do. And vice versa. People saying, I can't imagine ever accepting a feeding tube, and I don't ever want to have one, no matter what. To saying that maybe being on a ventilator wouldn't be so bad, to, I don't want to be on this ventilator anymore, and I don't want to continue on like this. And what do I do now? So this is a really important aspect to this psychological accommodations that people have over time to being sick. And this is different for different people. And there's no way to know how you're going to feel when you arrive at this point. And that's okay. I'm just making the point that it would be, it behooves us as care providers to make sure that the door is open to these conversations, so that we can tailor your needs to you as your quality of life perceptions evolve. So common considerations that inform someone's perceptions of their quality of life can be their use of non-invasive pressure ventilation, so external ventilation options, having a trach, which is a external opening at the base of your throat that allows air to bypass the nasal passage and go a shorter distance into the trachea. PEG tube refers to the feeding tube. Communication devices refers to computers and other devices that help you communicate. Residential options refers to where you would be living, depending on what support options you have and who can care for you. Discussing hospice care, which is advanced, highly specialized care at the end of life, which we will also discuss. And then, as I referred to earlier, code status. So triggers for serious illness communications and these advanced care discussions can also revolve around very specific disease markers. So, for example, when it's time to talk about a feeding tube, it can be in the setting of someone having respiratory decline, such that eating is a really big chore and they're losing a lot of weight, or for individuals who have phase onset of their disease. The need for non-invasive ventilation can also be a trigger. Now that you are needing it, let's talk through what this looks like and how do you start and stop, and under what conditions would you want to stop. Hospice care discussions revolve around when the person's prognosis seems to have reached 6 months or less, based on weight loss, debility, respiratory impairment, and life-limiting complications, such as pneumonias, urinary tract infections, things of that nature. And sometimes it's all of these all at once, depending on the individual and how sick they are and how advanced they are with their disease. And I just wanted to make a point to say that feeding tubes can be placed and then used and then not used, or you can have it placed and change your mind and then not use it anymore. And ventilation can always be withdrawn. So, none of these decisions are etched in marble for perpetuity, but rather they can be flexible depending on where you are with your feelings about how things are going for you and what's important to you and what your quality of life perception are. So we've covered a lot of aspects of palliative care. So let's then transition to what is hospice care. So hospice care is both a philosophy and a healthcare service here in the United States. And a lot of other countries, there's no such word as hospice. And when they say palliative care, they're referring to kind of both, hospice and palliative kind of rolled into one, which can be really confusing. And I wish it wasn't like that, but as far as I can tell, that's how it is. Hospice care here in the United States aims to provide comfort through maximally treating symptoms and focusing on quality of life. Think back to that total pain concept that I reviewed earlier for the person with the illness and their care partners. A big misunderstanding is that hospice does not provide 24-hour nursing / custodial care. They do not cover room and board, and that they do not cover medications that are not related to comfort and whatever the terminal illness is that has made them eligible for hospice. So that means if you're in hospice for ALS, hospice would not cover medications for, let's say, prostate cancer, for example. So where is hospice provided and who pays for it? So hospice is largely delivered at home with the nurse and home health aide, social workers, chaplain, the entire multidisciplinary team coming to the person at home. It can also be provided in nursing homes and assisted living facilities for those individuals who that's where they are and need to be. And it can rarely be provided in hospitals. Usually that's referred to as comfort care. Some hospices have their own hospice units for people who meet criteria for general inpatient care, which is above what we need to talk about today. But just know that some hospices have inpatient units. Who pays for hospice? It is an insurance benefit in the United States for those individuals who are on Medicare. Medicare Part A is the hospitalization benefit, and that's essentially where hospice is traded in for this Part A. So that means that when you enroll in hospice, that rather than coming back to the emergency department and inpatient care in a hospital, hospice is your new insurance plan and all of your healthcare rolled into one. It also is paid for by Medicaid. Most private insurance plans also have hospice coverage, as do HMO plans. And hospice care can also be provided to those regardless of their ability to pay, their insurance status, and their citizenship status. So hospice care basics for people who have ALS refers to those who have severely impaired breathing, really significant shortness of breath or air hunger at rest, those who have a lung capacity of less than 30% predicted, those who require constant oxygen in order to maintain life, or those individuals who have declined to have medically provided ventilation. And hospice care focuses on caring for the whole person, as I referred to, and their family members. And this is, as far as when, this is referring to when that person with the illness has decided that they no longer want to pursue external ventilation and want to focus on maximizing symptom management, comfort, and quality of life, because they've realized that the disease-modifying restorative care treatments are no longer benefiting them, or they feel that the burdens of all of these interventions outweigh their benefits. And to enroll in hospice, you do not have to be full code. You can still be full code, I mean to say, so that is not a barrier in and of itself. Some other hospice ALS eligibility guidelines I just wanted to make you aware of. Some individuals will have rapid disease progression, and there's a special set of guidelines for those individuals. So within the last 12 months, if someone has become gone from independent ambulation to wheelchair or being bedbound, that they went from having normal speech to being unintelligible. They went from eating normal diet to only being able to eat pureed. and they went from being completely independent in all of their activities of daily living, meaning dressing, feeding, showering, all of those things, to needing major assistance to do all of those things. And to have one of the following: so severe nutritional impairment, so inadequate ability to take in orally, weight loss, dehydration, and not have a feeding tube, for example, or life-threatening communication and complication, I meant to say, in the last 12 months, such as recurrent aspiration pneumonia, urinary tract infections, sepsis, recurrent fever after antibiotics, and then severe bed sores that are not healing and are deep. So in summary, I hope that I have helped explain very briefly what palliative medicine is, and that it is a person-centered approach that's appropriate at any stage of time across the illness trajectory, that it aims to provide an extra layer of support, and that includes for people living with ALS and their care partners, that hospice is a distinct healthcare entity, separate from palliative care, that is aiming to provide specialized end-of-life care that has specific eligibility criteria, meaning that you can't accidentally end up in hospice care. There's absolutely no way that could happen. So no worries about that. And that personalized medicine in this day and age, in my opinion, is truly operationalized when person-centered care is concurrently provided with disease-modifying treatments for as long as the person wants them. And I think this quote is very, apt to the human condition, and that illness and death are not optional, and that as clinicians, we have to recognize that our patients have the right to determine how they approach them, and that it's our job to meet them where they are, and recognize that that can be an evolving concept for them. And with that, I would like to thank you for your attention, and I'm going to turn the floor over to my colleague. Thank you.
Thank you, Dr. Leeper. And now, ladies and gentlemen, it is a great honor and excitement that I would like to introduce our next amazing speaker for today's webinar, Ms. Patricia Walsh. Ms. Walsh is a highly accomplished adult gerontology primary care nurse practitioner and advanced certified hospice and palliative care nurse. She has 10 years of community-based practice experience with both hospice and palliative care teams. She served most recently as a director of palliative care for Unity Hospice and Palliative Care, where she provided clinical and programmatic leadership for interdisciplinary palliative care teams in 5 locations across 4 states. She is currently a doctoral student at the University of Illinois at Chicago, and adjunct faculty in their hospice and palliative care certificate program. Her interests include support of development and retention of the palliative care workforce, support of care partners in their home, and the role of humanities in self-care and meaning-making for hospice and palliative care professionals. We are incredibly fortunate to have Patricia as our speaker today. I invite you to join me in welcoming her to the virtual stage.
Thank you so much, Jemana. I'm going to go ahead and share my screen if you'll bear with me for just one moment. Okay, there we go. So thank you so much. I'm really just delighted to be here with you. Thank you, Jemana and the ALS Association, and thank you, Dr. Leeper. So, it was my great pleasure to serve as the Director of Palliative Care for Unity and to help to develop those programs and serve our patients and families in the community. And I've only recently left that role basically because I saw the need to seek out additional supports for families going through the journey with serious illness in the community. And my hope is to seek changes at the systemic level to support our families. Because the reality in the home is that it is a struggle, and sometimes the reality of our system can make patients and families feel like they are alone. So thank you again for having me here. So I'd like to take a slightly deeper dive into Dr. Leeper's objective, in which she defined palliative medicine as person-centered care for people living with serious illness. So again, what does this look like in the home? So the outcomes I hope to achieve in a brief presentation, and then we'll move on to a question and answer time, is really to describe how the interdisciplinary team supports that person-centered care, and to recognize how those defined domains of care help to support holistic care. So as Dr. Leeper pointed out, palliative care is by definition interdisciplinary. This is a definition provided by the Center to Advance Palliative Care. And the goal, again, is to improve quality of life for both the patient and the family. And palliative care is provided by a specially trained team of doctors, nurses, and other specialists. This, again, is community-based palliative care, which, again, by its nature, is going to be specialty second-degree care provided for patients. And we work together with the patient's other doctors to provide an extra layer of support. I think it's interesting to point out that Cecily Saunders, who Dr. Leeper discussed, was initially a social worker who found that in working with patients and families, she identified a need for a real specialty in focusing on patients and their experience at the end of life and dealing with serious illness. So she was a social worker who became a nurse, who then became a doctor. So she was, in fact, an interdisciplinary team of one, which again underscores that this is work that requires the entire team and an array of specialties in order to meet the needs of patients. And again, the unit of care is not just the patient, although that is certainly a focus, but to provide holistic care, we have to expand our focus to encompass the patient, their involved family, however one defines family, and the care partners in the home, which might be family members, paid caregivers, neighbors, and sometimes friends. We can't underemphasize the importance of supporting everyone, because our patient is only as well as those who are providing the care in the home. So we need that system of support to be strong, and we focus on keeping it secure by supporting everyone involved with the patient's care. So the interdisciplinary team, again, both palliative care and hospice are provisioned by an interdisciplinary team of providers. So here I would like to compare the typical interdisciplinary team as provided by my organization, Unity, for palliative care. It is important to note that while hospice is fairly standard across the country, thanks to clear regulations, community-based palliative care services vary tremendously. But my organization provides, we work together with a physician, a nurse practitioner who is the primary individual visiting the patient in the home, supported by social work and sometimes chaplain as appropriate. The hospice team is going to consist of the physician, the nurse. Again, the nurse has a leadership role in doing the initial assessment of needs in the home, and to a certain extent organizing the care of the other interdisciplinary team members. But so the physician, the nurse, social work, chaplain, nursing aide, and then the bereavement team. will all be involved with the hospice level of care. One of the more important things about the two levels of care, as Dr. Leeper had indicated, palliative care is sometimes viewed as encompassing what we are defining as palliative care and end-of-life palliative care, which is hospice level of care. And the handoff and communication between the palliative care team, which comes in to support the patient while they're still receiving curative therapies, that handoff to the hospice team when a patient, if and when they choose to forego curative therapies and make a shift in their care to hospice to support comfort-based needs, can be a huge comfort to patients and families, because once they are familiar with an organization, it doesn't feel like such a leap. And in some instances, the social worker in particular, these are typically going to be different teams, but sometimes social work can follow the patient from palliative care on through their hospice journey. So in terms of what is managed for patients, palliative care is structured around 8 domains of care as outlined by the clinical practice guidelines for quality palliative care, which are defined in the US by the National Coalition for Hospice and Palliative Care. I'll take a quick walk through what these are just to demonstrate what we mean by holistic care. Domain 1 is where we define how palliative care in the community will be provisioned for a specific patient. Excuse me. Who will the care team be? How will we interact with their other providers, including when they have a clinic-based palliative care team or other specialists? How often do we expect to visit? And what is the consult structure? So for patients, what that looks like is, which provider do I call for which types of needs, right? So we want to set up a very clear structure so patients and families understand how to proceed through the care. Next, we take a look at physical aspects of care. And I think when most people think about palliative care, this is what they think of. They think, okay, symptom management, and that's the focus. And it certainly is, but it's not, as you can see, all that we focus on. Physical aspects of care will include defining those curative therapies that are ongoing. It will include symptom management and ensuring that we're mindful of any medication interactions. We certainly stay in close communication with different physicians providing care and coordinating to make sure that the needs that we see and the plans that we set in place for those patients are in alignment with the perspectives of their other physicians and family caregivers. We also look at functional support, and in many cases, we can report back declines to the team in clinic before, in some cases, they are able to assess for themselves. Domain 3, psychological and psychiatric aspects of care. Again, we're working on mood support in many cases. These are difficult illnesses to deal with, and that may require both pharmacologic or non-pharmacological supports, counseling, therapy, and things like that. So we can make referrals as necessary if specialty psychiatric care may be indicated. And again, we're coordinating with existing providers. For social aspects of care, our social workers are going to come in and identify if it's a family with resource challenges, are there concrete needs? Is the family in alignment, or is there dysfunction that we can help to bridge by having family conferences and bringing everyone to a similar place of understanding? Is it appropriate to engage with specialty support services for patients and care partners? And certainly we can consult regarding recommendations for caregiving services or facilities in some instances. We're definitely going to come in and assess for spiritual distress and bring in chaplaincy if that's appropriate. Sometimes patients are comforted by life review, and that can be faith-based or secular. We are going to provide support if there are any existential crises that one experiences in going through the disease progress. And we realize that different families, different faiths, different cultures have different perspectives on suffering. So we can enter into those conversations as appropriate. Domain 7 is focused on care of the patient nearing the end of life. So, advanced care conversations regarding preferred location of care as the disease progresses. Family readiness to provide care and engage with stated wishes. Sometimes the patient's wishes may be viewed as difficult or challenging to the family. So we help to make sure everyone is on the same page to enact those wishes if there comes a time when that's appropriate. And we talk about desired and non-desired interventions. And again, as Dr. Leeper so succinctly pointed out, those perspectives certainly can evolve over time. So these are always going to be ongoing conversations. Finally, we look at ethical and legal aspects of care, apply principles of biomedical ethics to any problems or disputes among the patient and care partners and families. We will help guide the conversations that can lead to setting forth a decision maker is using power of attorney for healthcare form, or creating a practitioner's orders for life-sustaining treatment to set forth wishes following a conversation. Setting up a 5 wishes or living well. There are different forms that can be used. The real essential focus, though, is in having the conversation and making sure that those care partners that will be called on to enact those wishes are aware and are prepared to support them. So as you can imagine, communication between the patient, family, and all care partners can be a challenge. This is a disease that very often can quickly start to limit communication, even in the best of circumstances. Because there is so much complex information to navigate with our ALS patients in the home, a team at Unity has developed our ALS Values Assessment Guide, which is divided into sections focusing on the clinical team, the personal team, those family members and care partners who are involved, and the patient's choices or wishes regarding particular interventions. Again, to capture those evolving perspectives and preferences that Dr. Leeper had discussed. And you can imagine, again, fatigue and exhaustion can really limit these conversations. And it's another reason for supporting early referral to specialty level palliative care so that we can have baby steps to work through these important decisions. I've even heard it referred to as microdosing of advanced care planning conversations. And I think that's a good way to put it, because not only can it be emotionally exhausting, but again, when fatigue is going to impact the ability to form words, or if someone is already working with a communication device, the fatigue and exhaustion can really slow down or limit how much communication can occur. So viewing this as an ongoing, ever-changing process, I think can be helpful. So finally, again, we'll get right to our questions, but I want to thank all the patients that have shared their journeys with me. I career changed from an earlier career in education to become a nurse, because I felt a strong desire after losing 5 loved ones in the space of about 13 months. I felt a strong desire to just be helpful, more helpful in the world. And working in palliative care in the community, where I have helped served patients and families from Highwood to Shorewood, from South Shore out to Schaumburg. It has been it's been a tremendous honor to put my energy toward relieving suffering, and what families share with me when I go into their home. I certainly feel as though I have received more than I have given. And so this is a statement from a physician that I'm honored to work with, Dr. Usha Mehta, to make of the journey a pilgrimage. As Dr. Leeper noted, this is a journey we did not have the choice as to whether to make, but I think that we can make choices along the way to create meaning from a journey such as this, and therefore to make of the journey a pilgrimage. So again, thank you. And I think perhaps we're ready for questions.
Thank you so much, Patricia. Sure, we can take a few questions right now. So there is one comment in the Q&A, which is an update on what Dr. Leeper shared about the Radicava. So it is now available in oral form, and there is Relyvrio as well, which is the Amylyx form. So this is just an update. So anybody that has a question, please feel free to type it in the Q&A, and we have another 20 minutes to share. But I did receive a question in an email because we asked people to send us some questions. So I will be sharing one. Although Patricia did share a little bit of this response, but I will say the question and please feel free to elaborate. So the question is, I am 76. I have and still do enjoy life. However, I am one of those patients who are not in favor of any sort of artificial prolongation of my life, neither by a feeding tube nor by any sort of mechanical assisted breathing device. I have compelling reasons for this, which I will not go into. Do you have any information regarding palliative medicine for those like me? My medical power of attorney is my friend and a retired neurologist. I have discussed this with him and written it in my living will. What else can be or should be discussed in advance with regard to my special, but probably not unheard of situation?
That's an excellent question. Patricia, do you want to take that first for someone who's in the community and potentially eligible?
Sure. So if I could just clarify once more. So basically you're wanting minimal interventions and you're just seeking comfort. Is that correct, as I understand it?
So it is not assisted suicide per se, but just not prolonging life, just.
Yeah, I don't think it's unusual. I mean, we certainly experience patients who say, I feel that I've lived a wonderful life, and the energy that I would put towards interventions, I think will not give me a cost benefit in terms of, slowing down the disease. So what we go in with is then a plan of care for managing symptoms. So we think ahead towards what symptoms we may expect one to experience, and make sure that we talk through the options for palliating those symptoms, and understand at each step and at each possibility what the preference would be. And we would go from there. So it would be very individualized for each individual in terms of the experience of symptoms.
Yeah, I think I would have to know a little bit more about what symptoms she's having now to get a sense of how things might be changing in the future for her, meaning that someone who's having on a weekly to monthly basis noticing changes in their functioning, heralding that maybe their disease is rapidly progressing, that they might want to think through a little bit more about what they would want their care to look like at the end of life, and what they would want for options. And I think that would have to be in a conversation with a provider. So it's hard for me to kind of make grand statements without knowing more, but I would be inclined to say asking questions about at what point would you then be eligible for hospice care, and whether home-based palliative care might be an option. I like to refer people to home-based palliative care when they're older and when they don't maybe have a robust social support system. For this person, sounds like maybe she lives alone, or if she's asking someone, a non-family member, to be their healthcare power of attorney, makes me wonder if she's living alone, and that maybe there's more social roles that need to be filled, and that home-based palliative care might be helpful for them.
I have another question here. When patients have both palliative care and home health, is it more difficult to navigate care?
When they have both home health and community-based palliative care, or when they have
It sounds like a community based palliative care.
well, the goal is for it to be easier. I'll start with that. And we experience every different configuration where we may have a patient with palliative care with a specialty palliative clinic that we coordinate with, and they can also have home health. Again, unfortunately, our system can be really complex. The shift to hospice care is designed to really simplify things, where they kind of come in and that's the one go-to. But for people along the continuum where they're still receiving curative types of therapies and you bring palliative in, sometimes you do, it can feel like to patients, oh, this is one more group now that I have to deal with. But our goal is always to manage the care coordination so that we are keeping your teams elsewhere apprised of the situation that we observe in the home. So again, the goal is to simplify it, and I that is the experience of most patients as it's expressed to me. Dr. Leeper?
Yeah, I guess I would say that home health is often requested for specific medical reasons. So managing a wound, or providing support specifically for a device like a central line, or something of that nature. And that is completely separate from why someone is referred to home palliative care. Palliative care being seen like in clinic or by a virtual video visit with someone like me, that has nothing to do with home health. So it all depends on what you mean by palliative care. I would say that, like Patricia was pointing out, you wouldn't need home health and hospice care, because hospice will take care of everything. But for people who are pre-hospice, I would say not necessarily, because I think it depends on what the home health nurse is tasked with addressing.
I hope this answered your question, Brittany. How often should we expect to meet with an assigned palliative care specialist if the patient is in the advanced stages of ALS?
That's an excellent question. depends on where you're getting your care, what their standards are. So, that is up to the individual provider. So for someone like me, if I were doing it, I would almost be inclined to say weekly or every other week, just to keep track of how things are going, knowing that sudden changes are apt to happen. Because of the thing I'd be worried about is an acute change that would herald a completely different perspective on what we need to do to take care of the person who has the ALS. So I personally would probably keep a pretty, close interval of video visits or at least phone calls, keeping track of how things are going.
So I think a typical frequency for a community-based visit from the nurse practitioner is once a month in the home. We definitely see as things progress, or if there's a situation that is evolving, we're going to increase that up to every 2 weeks. On top of that, the NPs, the social workers, everybody's going to be very available. So we will have conversations about things that we're thinking might be happening soon or changes that we want to hear about. So a phone call, a text directly to the provider, things like this can always occur. So we want to hear from patients. We want to hear about questions. We want to hear about changes, and then we can be responsive to those types of issues. Again, it varies, but it's certainly, we expect the frequency to go up. And with ALS, we certainly expect change. What works today is not going to work tomorrow or the next day, maybe. So we get lots and lots of interaction and have lots of conversations with our ALS folks.
One more question. Who designates when hospice can occur? Doctor, family, or patient?
That's an excellent question. So it is the role of the physician to certify that someone is hospice eligible. So there are very specific criteria that are set forth. Believe it or not, the same people who run hospice are the same people who run Medicare. So CMS, and they have a website, and you can Google, CMS rules for hospice eligibility for ALS, and it's right there. So like what I had in my slide presentation, like that's really what the rules are. So I think that patients and families can absolutely be informed healthcare consumers and can use the internet to read about what these rules are. But it's, and I always I advocate for my patients and their family members to ask questions, that when they feel like I want to understand more about when am I eligible for this, to have a frank discussion with the neurologist about this. But I also tried to do my best to educate the neurologist to recognize when it's time, and also to coach them about having conversations, recognizing that hospice is approaching, is here, so that that benefit that discussion and that healthcare benefit can be brought to bear as soon as someone's ready for it. So I like it to be that hospice is brought to the person so that they know it's ready for them when they're ready for it, and so that there's not gaps of time where someone could really have been using all that support and they were doing without it. So that's my goal, and to have that gap not happen.
Absolutely. And in the community, it's not unusual for a family to say, we're ready, and we want to know as soon as we qualify. And so every visit is really going to focus on, are we there yet? Of course, we're covering everything else, but are we there yet? Do we think we meet those qualifications and those standards that are set forth? And again, for so many families, it is at some level a relief when they can avail themselves of those additional supports and services. So it's for some people, it is definitely a focus.
Great. This was the last question. So as we approach the end of our webinar, I want to take a moment to extend my heartfelt gratitude to our amazing speakers for sharing their expertise and knowledge with us tonight. Your insights have been truly valuable, and we are grateful for the time and effort you dedicated to making this event a success. Thank you. I would like to also express my sincere appreciation to all the attendees who joined us tonight. If you have any lingering questions or thoughts about anything regarding this topic after the webinar, please do not hesitate to reach out to us through email. We are always here to assist and support you in any way we can. We look forward to meeting you again in our future webinars and events. Until then, take care and have a wonderful evening. Goodbye now.
Thank you so much.
Thank you.